My name is Cameron Mashouf. It is a distinct honor to introduce Dr. Ho as our speaker tonight. This privilege is very personal to me. And there's a couple of reasons for that. I'm going to make it short, Dr. Ho. First, I may be the oldest practicing dentist in the county. Secondly, I know so I am more eligible to introduce a young department chairperson. Secondly, I know her for a long time, almost 20 years. This year, 2026, marks the 50th anniversary that I applied to work at University of Pacific. I was hired in 1976, and I started working there 3-4 days a week for 10 years. But what I want to tell you is the transformation from that time to what we have now. At that time, the reputation of University of Pacific Orthodontic Department was not that flattering. The UCSF Department of Orthodontics, they were making a point that UOP was just like a technical school. There was no science, there was no research, there was very little academic. We were wire benders and tooth straighteners. On top of that, there was very little diversity. There was no African American, there was no Asian among either the students or the faculty. There were no Latinos, there were no Middle Eastern. And then if somebody like me became a faculty, they always made fun of me for the way I dressed, the way I talked, all of that. But I was learning, so I loved them all anyways. I think Jurak might be the first person that was not Caucasian when he started the program. Anyway, this is one of the people that she and I know very well. The transformation started with when Dr. Dagoni appointment Dr. Boyd. It might have been like 35 years ago, 30 years ago. And then as the chairman of the orthodontics, the department became more inclusive and open to scientific inquiry. But the true transformation occurred when Dr. O assumed the leadership. With her interdisciplinary vision, which was shaped by graduate training in both pediatric dentistry and orthodontic, as well as having a PhD in oral biology, Dr. O brought in an exceptional scientific curiosity and a collaborative approach that had long been waiting to emerge. I can go on, but it is suffice to say that she elevated the orthodontic department to a stature that is not being envied by most other programs. I am really proud of her. It's my great pleasure to present Dr. Heesoo.
Good evening, everyone. First of all, thank you so much, Dr. Mashouf, for your really kind introduction. And it's a great honor for me to be here. This is the first time I am in the Santa Clara County Dental Society. I'm very impressed with all your enthusiasm, and I know there's a lot of the members in the Zoom. So it's nice to meet you. And this is especially, I met some familiar faces. So thank you so much for your kind invitation. So this is our dental school, University of Pacific, in San Francisco, downtown in San Francisco. It's been already 12 years since we moved to this location. I hope many of you visited there. Most currently, we are expanding with ambulatory surgery center and multidisciplinary advanced care clinics in the first floor, the corner of the school. This is a really big new 22 million project. This will allow us to better serve for our patients with complex special needs and strengthen our collaboration with the medical institutions such as Stanford. So today's my topic is about challenging dental conditions in growing patients. I'm going to talk about 3 conditions: short root anomaly, transposition, and multiple missing teeth, multiple congenitally missing teeth. These patients are usually first seen by general dentist or pediatric dentist during routine examination or panoramic radiographs. My goal tonight is not to turn you into orthodontist, but help you to recognize these problems early and understand what really matters in timing and space management, and feel more confidence guiding these patients and parents through multidisciplinary, long-term multidisciplinary treatment planning. I'm going to share several cases for each topic, and I'll share how I manage orthodontically. But I would say early detection is the single most important factor to achieve successful outcomes. So let's start with short root anomaly. So when we talk about short root anomaly, we are not talking about root resorption. This is the developmental condition. As you can see, this is a periapical X-ray. Short root anomaly means fully developed roots that are abnormally short and plump appearance, typically seen in the central incisors. But we also differentiate other causes of short roots. Of course, we know developing roots that looks very short, but this is normal. Sometimes impacted cuspid can resolve roots of adjacent teeth, as you can see in the central incisors. In this case, impacted cuspid is resolving roots of central and lateral incisors. Trauma, incisor trauma, can also disrupt root development. As you can see, these patients had incisor trauma, and you can see there's a splint there. And in the X-ray, you can see short root. Probably the root development was stopped at that point. Of course, sometimes orthodontic treatment can lead to root resorption, sometimes. Again, short root anomaly means fully developed roots that are abnormally short and plump. Most affected teeth are maxillary central incisors and mandibular second premolars. Normally, maxillary central incisors crown to root ratio is 1 to 1.6, which means central incisor root length should be 1.5 times the crown. But in short root anomaly, crown to root ratio is 1 to 1.1 or less. So as a single clinical rule, we can say if the root is similar to or shorter than the crown, that raise the red flag for short root anomaly. This is the examples of short root anomaly affected on maxillary central incisors. but not only locally present, but you can also see in this panoramic radiograph, it can be affect generalized pattern. This is a real case. Patient is a 12 years old female Hispanic patient presented in our clinic for orthodontic treatment. You can see patients need some orthodontic alignment and corrected crossbite. But when we look at X-ray, you can see some serious problem in the maxillary anterior teeth. She has a combined problem, short root anomaly and impacted cuspid on the right side. Impacted cuspid is further resolving maxillary central and lateral incisors. How can we treat this case? So then how common is the SLA? In the literature, prevalence of SLA ranges from 1.3 to 10%. It's a pretty large range. In Caucasian, the prevalence is about 2 to 3%, but in Asian, Mongolian, and Japanese, reported that the prevalence of SLA is almost 10%. Recently, Mexican and Hispanic has also high prevalence. So in overall, we can say higher prevalence is found in Asian and Hispanic population. And there's some significant sex difference. You can see here, the females are almost 3 times more often affected as the SLA than males. So in our clinic, we've also observed severe short root anomaly in our clinic more recently, especially in Hispanic patients. So one of our graduates, Tim Howard, class of 2020, studied prevalence of short root anomaly in our orthodontic patients as his master thesis. So he reviewed almost 900 patients, and he found about 10% of patients has SLA. Remember, definition of SLA, crown to root ratio is 1 to 1, about 1 to 1 or less. But if you look at in this table, highest prevalence were found in Asian and Hispanic, almost 11 to 12%. And he further studied SLA by severity, and especially look at by ethnicity. So mild means root length is almost the same as the crown. Moderate means root length is less than crown. If it is severe, severe means root length is shorter than even half of the crown. In this table, you can see we found more severe form of SLA is found in Hispanic. So he found 90 patients out of 896. Out of 90 patients, there were 15 very severe SLA. Out of 15, 14 patients were Hispanic. Only 1 patient was Asian. So most severe form of SLA was more common in Hispanic patients than Asian. So this graph shows contrast between 2 ethnicity. In Asian shows the milder form of SLA, almost 60% of SLA were fall into mild. On the other hand, Hispanic shows most moderate to severe SLA. So now I'd like to share some cases. I'm going to start with the mild form of SLA. This is Eric, 80-year-old Hispanic male patient referred from general dentist because his front teeth are sticking out. Now, you can see a little bit protrusive lips, convex profile. Intraorally, you can see malaligned incisors, proclined upper incisors with a large overjet. In panoramic radiograph, we suspected a short root anomaly on the maxillary central incisors, Actually, periapical X-ray confirmed that he has SLA on the maxillary central incisors. On the other hand, lateral incisor shows normal root development with a large open apices. So real big question is, should we treat now or defer? From traditional orthodontics perspective, we can treat his malocclusion at once in permanent dentition. But because of his SLA condition, we decided to treat now in mixed dentition. As you can see, his cephalometric radiographs, he shows a significant class 2 malocclusion, A and B angle of 7 degrees. So goal of phase 1 early treatment was to correct skeletal and dental class 2 early to reduce root resorption risk later on. Another rationale to treat class 2 malocclusion in his case early was that from the literature, we know immature teeth are more resistant to root resorption. So treatment plan was to have headgear, deliver headgear for skeletal class 2 correction to restrict maxillary growth, and maxillary partial fixed appliance, 2x4, 4 brackets on the incisor and the 2 molar brackets, 2x4 appliance to correct incisor alignment and also incisor proclination. Of course, we carefully monitor root resorption on the maxillary central incisors. This is 5 months into treatment. When you compare to initial, there's no significant root length changes, and the lateral incisor shows normal development. Now, this is at the end of phase 1 treatment. We achieved good alignment in the maxilla, and we reduced overjet and maxillary incisor proclination. Now he's in the retention. This is the final, at the end of phase 1, panoramic radiograph shows, again, there's not much changes in root length. And you can see here, lateral incisor is much longer than central incisors. And other premolars are developing now. So we carefully follow up and monitor his canine and premolar eruption. And we place a rolling arch to maintain leeway space for incisor alignments. We follow up until age 16. As you can see here, he's in full permanent dentition, including all second molars erupted, still maintained incisor alignment, good overjet overbite, class 1 buccal occlusion. You might say there's a little bit of malalignment issues in lower canine and premolar area, but patients and parents are very happy with the result. And we also think this does not require second phase of orthodontic treatment. So I would say the early intervention successfully addressed his class 2 malocclusion. Now we want to look at panoramic radiograph, right? And then again, maxillary central incisor root seems okay. Very interesting is these premolars are also very short. Remember, we did not have any treatment in the lower arch except lower lingual arch. And then these upper premolar didn't have any orthodontic force. So what if we did not treat and we tried to correct severe class 2 problems in this permanent dentition? Because although his SLA is not very severe, but it will limit some significant tooth movement. Now I'd like to show a little bit severe short root anomaly. This is Alexa. She's a 10-year-old Hispanic female, referred by her dentist, again, because her teeth are sticking out and a lot of space. And she did not have any medical history. So you can see here, large overjet, almost a 9 millimeter, and with some spacing. When we look at panel and from convexity, you can see maxillary central incisors are very short. Cross-section view shows root length is shorter than half of the crown. That confirms very severe form of SLA. How can we treat this case? She has 9 millimeter overjet. How can we retract these central incisors? So question again, should we treat now or defer? Again, same reasoning. We decided to treat now. So phase 1 treatment objectives was to reduce skeletal dental class 2 and retract the maxillary incisors to reduce overjet and reduce proclination. By certified headgear to correct the class 2 skeletal problem. And at the time, clear aligner, Invisalign first was introduced at the time. So for her, we decided to use clear aligner therapy. So this is a progress. Oops. It's very sensitive. This is a progress. So reason she is wearing headgear is reducing overjet, not just with the tooth movement. We want to hold maxillary growth while mandible grow normally. Normal growth will reduce overjet. And dentally, we also very slowly with life force, we want to retract upper incisors. So now you can see overjet was reduced about half and space is getting closed. She's still wearing headgear at nighttime. And also we used 2-week interval aligner changes to reduce the force and also give some time to recover. And if you look at panoramic X-ray, central incisor compared from initial panel, there's not much root length changes. Okay, this is a more severe case with a generalized SLA. This is Vanessa, 11-year-old Hispanic female. Patients actually came to our clinic for orthodontic treatment. As you can see, she has a very convex profile. And when you look at the intraoral pictures, V-shaped maxillary arch with crowding, severe crowding. And if you look at side view, there's significant overjet. And another interesting thing you can see here, she has a transposition, maxillary rise, canine and lateral incisor were transposed. And upper left canine was erupting, top of the lateral incisors. When you look at X-rays, this is her panoramic radiographs. How are we gonna treat in this case? Almost no roots on the central lateral incisors. When you look at cross-section view, this is upper right to lateral incisor number 7. This is a severe form of SLA, root is shorter than crown. And then upper right canine and central incisor. Upper right canine is erupting and pushing upper right central incisor labially. And central incisor does not have any root structure. And this is the upper left one, central incisor number 9. In this central incisor has a very short root, maybe you can say 1 or 2 millimeter root remaining. Upper left is lateral and canine. You can see lateral incisor number 10 also has no root remaining. So damage is already done, so we can't make it irreversible. So this is central, upper right central, and upper left lateral incisor needed to go. So extraction was planned. And also significant orthodontic tooth movement is contraindicated in this case. So we extracted upper left right central and upper left lateral incisor. And then observe observe canine eruption. So you can see here canine erupted on the extraction site. And because the patient has a very narrow V-shaped arch and with some anterior crossbite, we decided to use maxillary expansion to develop arch form. We used a removable appliance to have a slow expansion. So now this is after expansion. You can see arch form developed nicely. So if you look at panoramic radiograph, initial and follow-up, now you can see all premolar erupted. And interestingly, this central upper left central incisor, although root is only 1 or 2 millimeter remaining, but clinically pretty stable. So we decided to keep this tooth as long as possible. So here we are. So we are now in the process of studying Invisalign clear aligner therapy. And the goal of clear aligner therapy is to distribute the space for this canine restoration in the future, because canine will replace the central incisor, left canine will replace the lateral incisor. So we collaborated with the prosthontist. We developed the design of the space distribution. So we are in the process of studying Invisalign treatment. Okay, last case for short root anomaly. This patient is an almost adult, almost 20 years old, Hispanic female. Okay, so I show you all Hispanic patients. She came to our clinic, wants to resume orthodontic treatment. What does it mean? Because she had very brief orthodontic treatment in her home country, and then she had to come to California. So she mentioned that she had braced a couple of brackets on the maxillary arch for 5 months. And she also had a stay plate for cover missing teeth. When we look at panoramic radiographs and the set, you can see upper incisors are very proclined, and then roots are very short, especially central incisors are very short, and canine is erupting. Premolars also very short. And then also she had one lower left first molar was extracted and the second molar medially tipped. So how are we going to treat this case? So this is after removing all appliance. So in this case, because her incisors are very short, but putting canine down, Invisalign may not be very predictable. So we decided to use a hybrid method, which means using some fixed appliance and clear aligner together. So we used auxiliary canine extrusion spring to bring maxillary left canine, and also upright lower left second molars. If this patient has a healthy periodontium and a healthy root, we might have bring second molar, third molar into first, second molar place. But because of her short root anomaly condition, we decided to just upright second molar and then leave space for implant in the future. So once we removed, extrude canine using fixed appliance, this is 9 months into treatment. So you can see canine is already extruded and aligned in the arch. And now we are starting to close the space very slowly. It's 12 months into treatment, but very minimum changes, but good direction. So this is initial X-ray, periapical X-ray. This is after 12 months of treatment. You can see space is getting closed and canine is into the arch, and but there's not much changes in root length. So as I mentioned, we decided to upright the second, third molar and leave space for implant. Okay, so now is a summary for short root anomaly. Short root anomaly is a genetically determined developmental condition. It's not a root resorption. Severe forms are more commonly observed in Hispanic patients. This is very important clinical implication. As the Hispanic population grew in this country, and especially in California, we're going to see more and more, we expect to see more and more severe form of SLA in our patient population. So early recognition is very, very important. And of course, a timely orthodontic intervention will be the key factor for the successful outcome. When orthodontics is indicated, life-first and longer activation intervals are essential for preserve short root. Okay, now let's move on to next topic, tooth transposition. So what is tooth transposition? Tooth transposition is defined as the positional interchange. This is a spatial problem. A positional interchange of two neighboring teeth, especially their roots. As you can see, canine and premolar are transposed. We can also, when we talk about the transposition, we also look at whether it is a complete transposition, sometimes we call true transposition, or incomplete transposition. Incomplete transposition means when only the crowns are transposed while the roots remain in the right position, the normal position. We typically see incomplete transposition in the impacted cuspid case, as you can see here. Although crowns in between central and lateral incisor, but root are correct position. So in this case, it will be incomplete transposition. In this case, also impacted cuspid. Cuspid roots is the correct position, but crown is try to erupt in between central and lateral incisor. You know, in treatment point of view, incomplete transposition is little bit easier to correct to ideal position. So then what is the prevalence of tooth transposition? This is according to large meta-analysis listed in this paper. Prevalence of tooth transposition is relatively low. Mean prevalence is 0.3%. So 3 out of 1,000 cases. And there's no male and female sex difference. But more often, you can probably see in the maxilla than mandible, and also it occurs more unilaterally than bilaterally. Then when we talk about treatment option, it really depends on the severity and also eruption stage. When we see incomplete transposition and also it is not fully erupted, we can do some interceptive treatment, such as strategic extraction of primary teeth to guide some eruption of premolars or canine, or sometimes do some expansion, provide more space to erupt. So in this case, more successful in incomplete transposition. But when teeth are already fully erupted as in transposed position, simple treatment option will be accept the transposed position. If we want to treat, there's a couple options. We can extract one of the transposed teeth. That can be good compromise. Most ideally, we can correct the transposition, but of course there's a high risk of root resorption or some periodontal damage. And also it's going to take a long time. So now I'd like to show you some cases for each options. Okay, first case, 12 years old female presented in our clinic for orthodontic treatment. She presented class 3 malocclusion. Can you notice some transposition? Yeah. So nicely transposed canine and premolar. It's a transposed. Should we treat? should we correct this transposition? Probably not. So we're gonna just accept in this case. If you look at panoramic radiographs, the roots are completely transposed. This is a complete transposition, and these are already fully adopted. So this is initial before treatment, and this is after treatment. So we accept transposition. So you can see here, because now premolar replaced the canine. So you like to improve gingival aesthetics, right? The upper left premolar, you want to do some gingivectomy to increase crown height. So we recommend patients to have gingivectomy, but patients' parents are very happy with the results, so they don't want to pursue gingivectomy. This is a very interesting, rare case because the transposition is very rare in the mandible, mostly in the maxilla. This is transposition in the mandible. So she is a 16-year-old female presented in our clinic, actually referred by general dentist. She just had extraction done on the lower right first molar. And general dentist referred because of something here. So you can see something going on here. So at first I thought, oh, this is a submerged primary molar. Maybe she has a congenital missing second premolar, right? So when we look at X-ray, what do we see? Yeah, so primary molars was enclosed and submerged, individually tipped, and then there's some bone defect there. But second premolar would exist. They're present, but migrated to distal of the first molar. And when we look at the combine CT, actually, this is looking at the distal root. Second premolar is resolving distal root of the first molar quite significantly, and then leaving just a little bit of labial wall of the distal root. So what should we do? So we discussed a couple options. One option would be extract and close the primary molar and extract the first molar and bring second premolar to the correct position and then place one implant. That was one option. Another option, of course, extract enclosed second primary molar and move this first molar onto second premolar place and then let second premolar erupt and then transpose the position. We discussed these two options with parents. The parents, of course, wants to choose less implant option, right? Because she already has needed to have one implant, which is a very upsetting situation. So, of course, we talk about some root resorption possibility, but they want to pursue the second option. So that's what we did. So after extraction, we moved first molar into the second premolar position. And then when you look at here, we provide space for premolar. And I thought at first we needed to do surgical exposure and tracking, but actually not. It actually, second premolar was spontaneously erupting. So you can see some peeking through there. So that's how we finished. Of course, we got some root resorption of first molar, but clinically very stable. So if you look at occlusal view, it's a little bit weird. The premolar is between big molars, but buccal view looks reasonable. And I think she can keep this as long as possible. Okay, so now let's talk about extraction option. I think I showed this panoramic radiographs earlier. This is the situation. Young patients came to have orthodontic treatment, and we found impacted cuspid is resorbing central and lateral incisor. And especially upper left central incisor roots are very short, about only 2-3 millimeter remaining. And she's young patients. And when you look at supplementary radiographs, you can see she's very protrusive. So if she has all normal teeth, this will be straightforward 4 bicuspid extraction case to retract the premolars and then retract to improve profile. But in this situation, which teeth we should extract? Should we still extract the premolars? So if we look at, okay, each quadrant need to extract one tooth, then upper left, which one we should extract? So we decide to extract central incisor, and then right side, first premolar. But if you look at the lower premolars, you can see second premolar is short, right? So that was also SLA. So rather than extracting long root, first premolar with a long root, we decided to extract second premolars. So 3 premolar and 1 central incisor reserved by impacted cuspid. So after extracting central incisors, we are tracking cuspid into central incisor position. Now it's fully erupted. Because we needed to restore, we open up space, medial distal, to provide space for restoration. And then now, after the restoration, we put bracket back and then close space. So this was initial. And this is how we finish. I think a frontal view looks reasonable. It's good. I don't think anyone will notice that was a canine. But if you look at occlusal view, you can see large buccolingual width of the canine. And if you look at panoramic radiographs, I think we got good root parallelism and without much reducing root length. This case was awarded for JCO Student of the Year award by treated residents was Bianca Lau. So she received this award for this case. And then this case was published in JCO article. Okay, now let's look at last option, correcting transposition. This is the most ideal kind of approach. So 80-year-old male, Ben, presented in our clinic for orthodontic treatment. He shows a little bit of a crowding, nothing much, crowding in the maxillary arch and the mandibular arch. When you look at panoramic radiographs, left side looks normal, canine and 2 premolars. But right side, what do you see? The premolars is more ahead of canine, right? So that is transposition. So what are we gonna do at this point? Nothing much we can do, right? So we extracted primary canine and primary molar, hoping that maybe improve a little bit. But we know it's not going to correct it completely because this is a complete transposition. If it was incomplete transposition, that definitely improve eruption path because that allows premolar erupt first and then canine later. So that will improve. But this is a complete transposition, which means the root position is switched. So we know it's not going to improve, but anyway, we did extract the primary teeth and waited. And then, as you can see, the canine is erupting between first and second premolars. So at this point, we have to make a decision. If we will wait further, then we miss the opportunity to correct. And then we discussed with the parents, two options, whether accept. If it accept, this is pretty straightforward. Just open up space between premolars and then canine will be just dropped down. It'll be easy. But if you decide to correct, we need some comprehensive mechanics we have to use. So we discussed with parents, pros and cons and risks, what risk is involved. And mom is dentist. What do you think? Mom is dentist. Mom wants to correct this transposition. So we decide to correct. So when we try to correct transposition, some important considerations in biomechanically, which need to think about how we can provide space for canine to pass premolars. So the very important thing is avoiding the two teeth colliding each other during tooth movement. So first thing we have to do is create space for canine. So how are we going to do? So move premolar more lingually, although it's going to be malaligned position, but move premolar more lingually and move canine more buccally or even slightly intrusive force. That way we can separate these two teeth each other. The intrusion is also important because tooth erupt, then there's more structures. So we want to apply a little bit of intrusive force and the labial force, and then bring premolar more palatally so that provide space for passing each other. So once it's a passing, then you can bring canine down. That's what we did. So this is the final. So you can see canine and premolar is switched. Okay, so this is the final panoramic radiographs. I think we got good root parallelism, but we lost some root length, right? We got some root shortening of premolars. So as you can see here, this was initial, and this is, but we discussed with the parents that there would happen because the premolar had to move a long distance. So summary for tooth transposition. Again, early detection, early identification of this condition, transposition, is very critical. Timing determines whether correction is possible or a risk. As I mentioned, if it's already erupted, like halfway erupted, it's more difficult to correct. So when tooth has not fully erupted, there's a chance to correct. Of course, some comprehensive mechanics needed to apply, but there's a chance. But if it's fully erupted, it is very difficult to correct the transposition. It's more difficult to correct the transposition in the mandibular arch because mandibular arch alveolus is much narrower than the maxilla. There's no room to safely passing each other. So the timing is really, really important. And if it is incomplete transposition, strategic extraction of primary teeth can guide a favorable eruption path. So there's good prognosis. If we want to correct, we have to act quickly before full eruption of the tooth. When correcting transposition, sequence and biomechanics matter to minimize the root damage and reduce treatment time. Okay, now let's move on to our final topic, multiple congenitally missing teeth. This is a very complicated condition and also require multidisciplinary approach. Okay, so when we talk about multiple congenital missing teeth, clinically we use these three terms. Anodontia means the complete absence of all teeth, which is extremely rare and mostly syndromic. Oligodontia means 6 or more teeth missing. Hypodontia means fewer than 6 teeth missing, which what we most commonly see in the clinic. So when patients have multiple congenitally missing teeth, the problem goes beyond aesthetics. It significantly impacts facial growth. So think about if there's no teeth, congenitally missing means that there's no eruption force. Without eruption force, dental alveolar bone does not develop normally. So there will be lack of dental alveolar and underdeveloped alveolar ridge. So not only buccolingually, but vertically. Actually, vertically is more important. So it will lead to reduced vertical facial height. Consequently, it changes in jaw growth. And also, if more congenitally missing teeth are in the maxilla than mandible, then little more deficient maxilla than mandible, that will create more skeletal class 3 malocclusion. But if more congenital missing teeth are in the mandible than maxilla, then this will create more skeletal class 2 problems. So it depends on the situation. In this case, you can see the class 3 patients, more missing teeth on the maxilla that will create flattened facial profile and reduce the lip support. So this congenital missing teeth impact on facial growth as orthodontists, we have to really try to correct these skeletal problems early on. So then I would like to show you severe oligodontia case. Remember, oligodontia means 6 or more teeth missing. So this patient has more than 6 teeth missing. So Tenzin is 7 years, 10 months old, Asian female. She deferred from our periodontic department due to multiple missing teeth and crossbite. So what we see here in the clinically, very severe anterior-posterior crossbite, overclosure of the bite, and class 3 malocclusion. And she has only maxillary 2 central incisor and one first molar erupted, and the lower 2 lateral incisor and the first molar are erupted. So when we look at panoramic radiograph, she has 8 missing maxillary permanent teeth, including all canines and premolars in the maxilla, and the 3 missing mandibular teeth. So you can imagine why she has a severe class 3 relationship, more missing teeth in the maxilla, and that will lead to deficient lack of dental alveolar eruption. So she has severe class 3. And also, we don't know whether this is third molars or second molars, but we have some concern about the molar, developing molar. But good thing about this case, she has 3 maxillary incisors. This is a very important, good prognostic factor for future aesthetics. So cephalometric analysis shows she has a severe skeletal class 3, A and B angle of -4 degrees, and divergent. So basically, maxilla is deficient in all 3 dimensions, sagittally, APYs, and vertically, and also transversely. She has a posterior crossbite. Dentally, she shows -5 millimeter overjet and 7 millimeter overbite. And severe class 3 malocclusion, as you can see, the molar relationship there. And soft tissue-wise, concave profile. So, as I mentioned, if we leave this case without intervening for her class 3 malocclusion. She's going to have a more severe class 3 lack of maxillary growth. So goal of phase 1 treatment is to correct her skeletal class 3 problems. We're going to expand the maxilla because she has narrow maxilla with the posterior crossbite, expand the maxilla and protract maxilla to bring forward and make it mandible down and backward rotation. That will increase vertical height. And then dentally, we want to preserve all the primary teeth and correct anterior crossbite. We're going to use RPE, rapid palatal expander for maxillary expansion transversely, and face mask to protract the maxilla forward, and partial fixed appliance, 2x4, actually in her case, 2x3, because only 3 incisors, to align the incisors. So this is the 3 months into treatment. So as you can see, we already corrected posterior crossbite. We expanded significantly. And we delivered the face mask right after expander. So she was a very compliant patient. She wore face mask about 11 to 12 hours every day, every night. So in 3 months treatment, we can already see edge-to-edge bite. Remember, she was -5 millimeter overjet. So once we got some positive overjet, we placed fixed appliance to correct rotation and distribute the space between incisors. As you can see, her central incisors are very undersized, and also peglateral incisors. She has only 3 maxillary incisors. Others are all primary teeth. So we distribute the space after discussing with a prosthodontist, because the goal is to provide space for restoration, resin veneer restoration for these patients. So this is at the end of the treatment. You can see we corrected class 3, severe class 3 malocclusion. Now look at her profile. You can see now it's slightly even convex, which is normal for this age. And we got positive overjet and also overbite. And the molar relationship improved. If you look at final step, we increase AMB angle almost 5 degrees, and SNA increased 3 degrees, which means that much maxilla came forward. SNB decreased 2 degrees, which means mandible swing down and back, and increase mandibular plane angle 2 degrees. So this is a quick comparison of initial and final lateral set. You can visually, see how much maxilla came forward and the mandible swing down and back. Also take a look here. When we use a face mask, this face mask, RPE face mask, is not a bone-bone appliance, it's a tooth-to-bone appliance. So not only, because she's young, when we apply orthopedic force, skeletal protraction will be occur, but not only skeletal protraction, but also dental. So dentition is coming forward. So you can see distal of the first molar, how much space we have now. So then much dentition came forward, and look at the molar relationship. It was almost class 3 and then good class 1. So she was very good, good patients wearing face mask. Orthodontists use this is a parametric superimposition to evaluate actually what happened. So usually the forehead, the nose, and maxilla came forward almost the same magnitude. So SNA does not much change. But in this case, you can see maxilla came forward almost 2 to 3 times more than forehead. And the mandible, if you look at this mandibular superimposition, you can see mandible definitely got longer, it got bigger. However, if you look at overall superimposition, chin position did not came forward. How did it happen? Because with the face mask, we were able to rotate mandible down and back. So that's why mandibular plane angle increased. But we redirect mandibular growth more down and backward, not coming forward. That's how not only protract the maxilla, but we redirect mandibular growth more down and backward. That's how we improve in very short period of time, less than 2 years, we were able to correct a significant skeletal class 3.
Yeah.
So as you can see here, the maxilla came forward this much. Okay, again, this is a quick comparison of before and after treatment. She had a complete class 3 anterior posterior crossbite, but after about 20 months of treatment, you can see posterior anterior crossbite corrected and positive overset. And this is X-rays. So now her premolars, all premolar canine in the mandibular arch is all erupted. And if you look at the root of primary teeth, there's a slight shortening of roots, as I mentioned, because of that face mask, RPE face mask, not only skeletal orthopedic force, but there's some dental force. But there's clinically pretty stable. So our goal is to maintain the primary teeth as long as possible. One thing we are discussing now with oral surgeon, whether it would be a good idea to do some autotransplantation. Because the molar is developed, if we think first molar occlusion is sufficient, because I hear nowadays prosthodontists consider first molar occlusion is sufficient. So if that is the case, rather than leave all missing teeth in this area, because the lateral incised canine, 2 premolars all missing, whether autotransplantation can be a good idea. Because if we see these teeth mobile and it's going to lose, then I think, because autotransplantation needs to be done before root is more than 2/3 developed, before eruption. So currently we are discussing the possibility of autotransplantation. Okay. Now this is my last case, oligodontia. This is also severe oligodontia case. This is the male patient, 13 years old male patient. He was referred from private practitioner to our clinic. He does not have any genetic condition, the etiology. This is OP. You can see a little bit of flattened straight profile. And intraorally, you can see he already has Hydex appliance with denture teeth in the anterior region. And he has a history of face mask therapy. Also, you can see several primary teeth still there, the primary teeth. And in the lower, interestingly, he has a very severe posterior open bite. And we suspect some ankylosed primary molars. And the incisor shows edge-to-edge bite. So this is him at age 5. So actually, the treating orthodontist was one of our graduates. And when she treated this case first, she consulted me and we had treatment planning together. So I was able to involved in treatment planning and follow up over time. So what do you see? He is 5 years old. So he did not have primary incisors in the maxilla. So congenitally missing primary maxillary incisors and 1 mandibular incisor. So congenital primary teeth is very, very rare. We cannot believe he does not have any other genetic conditions. He is a very normal, healthy child. And his parents and siblings are all good. normal and no dental anomaly at all. But just he has this condition, congenitally missing from the primary dentition. So what does it mean? He never had front teeth. So from the very early on, we had to place kind of appliance with the dental teeth because we're concerned about the speech and not only aesthetics, but speech. And when we do RP expansion, we also split the dental teeth so that allow expansion can happen. So let's go back to at age 13 when he came to our clinic. This is a panoramic radiographs. So you can see he has 9 missing maxillary teeth, including all incisors, canines, and 3 premolars. Just he has 1 permanent premolar. And in the lower, he has missing 3 mandibular teeth. So again, more missing teeth in the maxilla will lead to severe skeletal class 3 problems. And also we can see this was ankylosed. And also, I don't know what happened, but the first molar, this is a permanent first molar, is intruded position. Later it confirmed as a true ankylosis. So he has multiple problems. So our plan was to continue protract maxilla because he's a 13, the boys, the peak of growth is about 14.5 to 15 years old. And then he is 13, which means he's going to grow a lot. So he has significant growth remaining. So we want to maximize his growth. So we try to get maximum protraction in the maxilla. He was very compliant. He knows his condition. He's very conscious about his condition, as you can imagine, never had a front teeth. So he knows, and then for him and his parents, surgery is no surgery, just to do whatever it takes, but no surgery. So we suggest we should then use a face mask to protract maxilla, and he said that he will do it. So he was a very good patient, although he was 13 years old. And bring maxilla forward will create maxilla a little bit more down, and also that will lead to mandible down, swing down and back, which I mentioned. Make it mandible more swing down and back rotation that will increase his vertical dimension, which is deficient at this time. Dentally, we want to extract all suspected ankylosed primary teeth and extrude molars to correct the posterior open bite and align remaining teeth with the prosthodontic plan. When we discussed with prosthodontist, suggest removable partial denture until growth is complete, and then after growth is done, probably implants, multiple implants, but until then, a partial denture will be the treatment plan. So this is the progress. So as I mentioned, we want to increase his vertical. So we added keep acrylic on the dental teeth. So that increase vertical, make it mandible swing down and back. And then increase posterior open bite. And then he wore a lot of elastic to extrude the teeth together. And also he wore a face mask at nighttime. So this is at the end of treatment after removing all appliance for the partial denture fabrication. So as you can see, although there's no teeth, you can see the canine is more forward position, which means we brought maxilla more forward. Then also enclosed first molar, we added more resin occlusal stops to have occlusion. So this is the final panel with the multiple missing teeth. And we delivered the maxillary partial denture. This is a temporary solution. That he's going to wear this partial denture until growth is completed. So this is my last case. So I like to kind of reflect the journey of this young boy with multiple congenitally missing teeth. As I mentioned, he never had front teeth. And he had to wear the appliance with denture teeth since when he was about 6.5 years old. And then now he's 15 years old. So think about that long journey. It is not just for him and a whole family. So when we removed all the appliances, he was overjoyed. And mother was in tears. They were so appreciative, all the effort, pediatric dentist, and previous orthodontist, and in our clinic, faculty, and he was so appreciative. And this reminds us, the moment like this reminds us of what we do, why we do what we do. It was really rewarding moment when we treat these complex cases. So summary for multiple congenitally missing teeth, again, early management of a skeletal discrepancy in multiple missing teeth is critical, especially missing teeth means no eruption force. Without eruption force, alveolar bone does not develop normally, not only baclolingually, but vertically. Vertical deficiency is the most important problem here. So we need to manage early skeletal discrepancy and preserve primary teeth as long as possible, whenever possible, but we have to really closely monitor whether there's any ankylosing, because ankylosing means that hold the bone, doesn't allow other tooth eruption, bone eruption. So we need to monitor ankylosed primary teeth. And of course, the multidisciplinary care is essential for future restoration. So final thought, I'd say panoramic radiograph in the mixed dentition is one of the most powerful tools we have for early detection. As I said, all this complex case require early detection. We could minimize the complexity if we identify problem early. So early diagnosis, timely orthodontic intervention, and multidisciplinary collaboration are key to managing these complex cases effectively. Okay. I hope I discussed today 3 challenging dental conditions: short root anomaly, tooth transposition, and multiple congenitally missing teeth. I hope my presentation today provided some insight into managing this complex developmental condition. Thank you for your attention, and I would be happy to take some questions if you have.
Thank you so much, Dr. O. We will go ahead and take a couple of questions.
Thank you.
And turn to our in-person room, starting with an online question. Do you recommend to splint short root teeth permanently?
Can you say again?
Do you recommend to splint short root teeth permanently?
Permanently. Unless there's significant mobility. I mean, if there's severe mobility, when we finish the treatment, we can place splint. But if you don't have much, although short root looks short, but sometimes you don't see much of mobility at the time, we don't recommend it to place a splint.
Fantastic, thank you. And a question from the room? Any hands? Yes, just a moment.
Hi, I had a question about short roots as well. So if there's a patient who doesn't essentially need ortho treatment, but has short roots, what can we tell them in terms of prognosis or any special, precautions they should take for long term?
Patient did not have any.
Doesn't need ortho treatment, but we
does not need orthodontic treatment, correct?
Yes, yes.
In that case, I think it's just a healthy like maintaining periodontium, like cleaning regularly.
What's the prognosis like? Pretty much like a normal tooth?
Yeah,
Okay.
yeah. I mean, all depends on how short we are talking about, right? Mild to moderate. Even I show you like a very short, 1 to 2 millimeter root remaining.
Mhm.
Those teeth were still stable, but I would place a splint in that kind of short root.
And would that be permanent rigid splint?
Yeah, permanent kind of wire and
Okay.
then put the resin. Yeah.
Got it. Thank you.
But we usually place a little bit flexible wire, like a multi-strained flexible wire to allow some physiologic movement. We don't want to put like a stiff wire. I think the concept has been changed. Before we place a stiff splint, but nowadays we want to allow some physiologic movement. So we place flexible multi-strained wire.
We'll take another question from online. What are the possible causes of developmental short roots? Does trauma to primary incisors affect root length for succeeding permanent incisors? Genetic components?
So SLA, short root anomaly, is a genetic developmental condition. So now we are many researchers are working on gene study. Because the many papers shows pedigree, there's a genetic component. So it is not a trauma. Trauma, as I mentioned, trauma can disturb root development, so can cause short root, but that is not short root anomaly.
Perfect. Thank you. Any other questions in the room? I see a hand.
For medium or like severe kind of SLA cases, is there a timeline we should be, sometimes if you find it in a young patient, like I did have a patient something similar 3 weeks ago, and the patient was not the dentition was otherwise okay. So, but the root did start showing to be, like, I saw this patient after a year, and I did see the root getting shorter. So is that something normal to keep seeing the root getting shorter over a period of time?
No, actually in SLA, it's not a root resorption, it's a developmentally short root.
Okay.
So if there's no external forces or trauma, then it will do not resorb.
Okay.
If it is impacted the cuspid or orthodontic force, then might root. Like the concern is that because it's already short, a little bit of root resorption from the orthodontic treatment is going to make it really short. And also first application, same amount of force, but root is short, then area unit per force per unit will be much bigger than normal tooth, right? That's why we are very careful about how much force we are applying. We like to apply very light force and then also give a little bit of interval between force application to give some recovery time. But if it is the real SLA, not from the trauma, because as I said, the trauma can cause short root, but that is not SLA. SLA is genetically. Yeah.
So how do you usually clinically determine the difference between that, if it would have been
so if
SLA compared to?
That's right. So SLA is mostly bilateral.
Okay.
Locally, central incisors is the most often occur, and then premolars.
Okay.
If it is like just one tooth is short root, maybe from trauma of the other causes. So usually symmetric, but locally most affected teeth are central incisors. Almost 90% of time is the central incisor. And sometimes the premolar together or premolar separately, but most often you can see the central incisor. But central incisor also can have an incisor trauma, right? So you are not really sure, but you have to take the history with the trauma. And also when you apply force, then sometimes the trauma causes the short root anomaly, then sometimes enclosed can happen. So there's no clear cut, this is from trauma, but yeah.
Understood. Thank you so much, doctor.
Thank you. I'll take a question here.
Yes. In the study, which showed that Hispanics have a greater number of short roots. Of the 950 people, was each ethnicity represented equally?
No, actually, so maybe I can go back to. So our clinic, about 40% of patients are Hispanic, and then 25% are Asian, and 25% are Caucasian. So percentage-wise, the number of patients, think, okay.
Since you had more Hispanic patients, you'd
That's
expect to have more
Yeah.
short roots.
Yes. So, but percentage is important. That's why percentage is important. So among Hispanic patients, the total you can see here, 46 patients were Hispanic, SLA, and then 25 Asian patient has SLA. But from this total, this is the percentage. So in Asian, 15 out of 25 are mild. So there's 60% of SLA from Asian has mild. And in here, if you look at it, 46 out of 46, 14 patients have a severe SLA. That's why percentage is 30%. So you are just looking at the within ethnicity, the percentage wise.
Thank you. Let me check our time, see if we have time for one more online question. Yes, we do have time for one more online question. These days, would you consider expanding the palate on the patient with a V-shaped upper arch with a MARP device that is anchored to the palate to create room for impacted teeth to erupt instead of extracting?
Oh, yes. Whenever we think expansion is needed, we do expand. It can be just a regular rapid plate expander, like tooth-borne appliance. Or sometimes when we expand, we have also dental effect. If we don't want to have a dental effect, we can place a microimplant, which is called MARPI. We can use MARPI, but of course, if expansion is needed. And the impacted cuspid, the study has been shown that if you provide more space, the impacted cuspid seems to improve. There's definitely space, providing more space for impacted cuspid is important, but also palatal impacted cuspid is less related to space issue. The labial impacted cuspid is more related to space. So I guess it depends, but expansion is a need. If it's a V-shape, high palate, you need a crossbite or buccally flared molars. If it's indication of a narrow maxilla, then we do expand. It can be regular expander or it can be MARPI using TED.
Fantastic. Thank you. If there are additional questions folks have after tonight, what is a resource you might recommend for them?
Any questions? Then for the topics?
Yes, on tonight's topic.
Yeah.
That's okay. I very much put you on the spot there. As a reminder, we will do our best to get some of this information up on sccds.org as well. Thank you once again, Dr. O, for this fantastic topic. And thank you, everybody who joined us. I will get your keyword slide up in just a moment.
Thank you.